Good morning, everyone. Today we are going to study about dysenteries and the drugs used in this condition. I'm Dr. Akash Vishwe, working as assistant professor in the Department of Pharmacology in Index Medical College. Okay, so let's start the topic about dysentery. So what is dysentery? Dysentery is an inflammatory disorder of the intestine, especially of the colon, that results in severe diarrhea containing mucus and uh, or blood in the feces with fever and abdominal pain, which is caused by kind of infection. So what are the causes of dysentery? Dysentery actually results from the viral infection or bacterial infection, or it could be parasitic infections. The two most common causes are, first one is the amoebic dysentery due to protozoal infection, mainly by Entamoeba histolytica. Another cause is actually bacillary dysentery, which is a bacterial infection mainly by Shigella. So here we have two types of the dysentery. Basically, one is the bacillary dysentery, which is caused by Shigella, or it is also known as the shigellosis. And another type of the dysentery is amoebic dysentery, which is also known as amoebiasis. This is caused by amoeba, like Entamoeba histolytica. So, what is the actually basic difference in between the amoebic dysentery versus bacillary dysentery? In amoebic dysentery, it is caused by an invasive protozoa parasite called Entamoeba histolytica. While in bacillary dysentery, it is a bacterial disease caused by a species of bacteria known as Shigella species. In amoebic dysentery, patients will have 6 to 8 episodes of the loose motions per day, while in the bacillary dysentery, patients will have more than 10 loose motions per day. It is uh, somewhat more heavier than the last one. So in amoebic dysentery, there is copious amount of the stool, while in bacillary dysentery, there is a small amount of stool. In amoebic dysentery, stool has a dark color and an offensive odor, while in bacillary dysentery, there is a fresh blood colored or odorless stool. In amoebic dysentery, RBCs clumped together with the numerous eosinophils, few pus cells, and the macrophages. While in the bacillary dysentery, there is discrete amounts of the RBCs, which will form Rolex, fewer eosinophils, and numerous pus cells and macrophages. While in the amoebic dysentery, it is treated with the anti-protozoal drugs, and bacillary dysentery is actually treated with the somewhat antibiotics. Now, first we are going to discuss about the bacillary dysentery treatment. So it is treated by, as we have seen earlier, by some specific antibiotics. So the examples are fluoroquinolones, such as ciprofloxacin, which acts by the inhibiting the DNA kyrase enzyme of the bacteria. Another antibiotic is cotrimoxazole. This is the combination of the trimethoprim and sulfamethoxazole. Children or patient allergic to sulfa drugs, parenteral ceftriaxone or oral cefixime, are safe and effective. Cefixime is third generation of the cephalosporin. Cotrimoxazole is commonly used in traveler's diarrhea. Now we have the another topic, that is amoebiasis, which is caused by the amoeba, Entamoeba histolytica. So what is amoebiasis? Amoebiasis is a protozoal infection which is caused by Entamoeba histolytica, and it is transmitted through fecal-oral route classification of the anti-amoebic drugs. So first one is the tissue amoebicides, that is nitroimidazoles. In this category, we have the drugs like metronidazole, very commonly known, metronidazole, tinidazole, ornidazole, secnidazole, and cetronidazole. Another category is the imatin group. So in this category, we have two main drugs. One is the imatin, and another one is the dihydroimatin. Short form is DHE. Another category of the drug is 4-aminophenolines. So the example is the chloroquinolone. After oral or IV administration, attains higher concentration in the blood and tissues. The drug is. Now, when we are going to talk about luminal and amoebicides, so here we have another three different categories of the drugs. First one is the amides, diloxanide and nitazoxanide. 8-hydroxyquinolines. So the drugs are idoquinol and idochlorhydroxyquine. Now, some antibiotics also we have used in this condition. So these are tetracyclines and paromomycin. Poorly absorbed after oral administration, these drugs attain higher concentration in the bowel, and these drugs act on the trophozoites in the gut lumen and kill them. So we are going to discuss first about nitroimidazole group. So the main drug is, the prototype is metronidazole. So this is actually nitroimidazole derivative. It is highly effective against most of the anaerobic bacteria and several protozoa. Example, Entamoeba histolytica, Giardia lamblia, and Trichomonas vaginalis, and D. medinensis, Dracunculus medinensis. So it is actually ineffective against anaerobes because in the presence of oxygen, highly reactive nitro radical cannot be generated. It is effective against anaerobe. So we use this. So what is the exact mechanism? So this metronidazole enters into the microorganism or bacteria. So nitro group of this drug accepts electron from the ferredoxins, and it is highly reactive. Nitro radicals are generated. And due to generation of this highly reactive nitro radicals, it damages the microbial DNA, and due to this reason, there is finally death of organism occurs. So this the pharmacokinetics of the metronidazole is, it is absorbed well orally, and it is distributed poorly. It is distributed poorly bound to the plasma proteins, diffuses well into the tissues, including brain. Therapeutic levels are achieved in the various body fluids like saliva, semen, vaginal secretion, bile, breast milk, and cerebrospinal fluid. It is metabolized in the liver and excreted out from the urine. So the adverse drug reactions of the metronidazole, more ADRs are on actually GIT tract. These are nausea, vomiting, abdominal cramp, epigastric distress, anorexia, metallic taste. And somewhat it is also allergic. Some allergic ADRs like rashes, urticaria, and itching can also be possible. So, and when we are talking about the central nervous system related areas, so these are dizziness, vertigo, confusion, irritability, and ataxia can be occurred. So the important thing what we have to remember that the metronidazole is the drug which can cause the disulfiram-like reaction. So if the patient takes alcohol and if he take this drug metronidazole for somewhat any bacterial infection related to that particular indication, so there would be possibility of the occurrence of the disulfiram like reactions like nausea, vomiting, headache, abdominal cramps, and flushing. So the physician have to be very cautious about this. You have to take the history of the patient actually. Now we have the drug interactions. So first, what we have just seen in the last PPT, metronidazole when combines with alcohol, so there is occurrence of the disulfiram like reactions. When metronidazole combines with lithium, so there is possibility of lithium toxicity due to decreased renal clearance of the lithium. When metronidazole adds on with warfarin or other coumarins, so there is increased possibility of their anticoagulant effect by decreasing their metabolism. So be cautious. Now the specific uses of metronidazole. So these are first one is the in the amoebiasis. Metronidazole 400 to 800 milligram thrice a day is generally is the drug of choice in the intestinal and extraintestinal amoebiasis for 7 to 10 days of duration. The drug diloxanide 500 milligram TDS can also be added on with the metronidazole in this condition. Another indication is for trichomonas vaginitis. Metronidazole 400 milligram TDS for 7 days is the drug of choice for this condition. In this condition, both partners should be treated, male and female. Another indication is the giardiasis. Metronidazole 200 milligram TDS for 7 days can be used. It helps in extraction of the guinea worms also. Metronidazole is also used in the condition of the Crohn's disease. Another indication of metronidazole is used in anaerobic infections. So metronidazole is highly active against anaerobic infections. Example, pelvic inflammatory disease, lung abscess, intra-abdominal infections, etc. caused by the Brevifacilis, Clostridium and other anaerobic organisms. Anaerobic brain abscess. In this condition, metronidazole plus third generation of the cephalosporin can be used. Antibiotic associated pseudomembranous colitis. Metronidazole is actually cheaper and less toxic than vancomycin, so more beneficial in this condition. Vincent angina. It is actually ulcerative gingival infection caused by anaerobes. So metronidazole plus amoxicillin are more beneficial. In the H. pylori infection, metronidazole plus amoxicillin plus PPI, proton pump inhibitor, actually used now these days. And it is also used as prophylaxis in colorectal surgery. Another drug is tinidazole. Tinidazole, the route of administration used is oral and IV in both the form in tablet and intravenous form. It is also available. Tinidazole used actually for the amoebiasis as per the metronidazole. Most indication it follows. So, in the amoebiasis, it is used in the 2 gram of quantity 1 OD for 3 days. While in the trichomoniasis and giardiasis, it has given 2 gram stat only. In anaerobic infections, it is used for treatment of the H. pylori and prophylaxis of the colorectal surgery. Advantages of tinidazole. It has a longer duration of action and better tolerability than the metronidazole. It is more used nowadays. Now, saxenadazole. Route of administration is oral, available in the tablet form. Uses are intestinal amoebiasis, trichomoniasis, and giardiasis. In these conditions, we give this drug only 2 gram stat. Advantages of saxenadazole: single dose spectrum, mechanism of action ADRs are similar to the metronidazole. Now, the ornidazole and cetronidazole. Route of administration will be oral and intravenous. Uses are intestinal amoebiasis, trichomoniasis, and giardiasis, and in the anaerobic infections. Advantages: longer duration of action and better tolerability than metronidazole. No disulfiram-like reactions with cetronidazole. Now, the another category of the anti-amoebic drug. So this is imatin group. Imatin is also known. Actually, it is also obtained. It is obtained from a Brazilian plant that is known as ipecac plant. So it is also known as the Brazilian root. So imatin and dihydroimatin. Imatin is actually ipecac alkaloid. And while the dihydroimatin is a semi-synthetic product which is obtained in the lab. The route of administration is intramuscular. It is it is bitter in taste, nauseating, and irritant capability. Mechanism of action. So it kills the tissue trophozoites and shows no effect on the cyst. Dihydroimatin is preferred over imatin because it is less toxic, used only patient not responding to the metronidazole. So dose is 60 mg 1 OD for 5 days. Duration of the treatment should not be exceed for the 10 days. Adverse drug reactions. So just we have our mnemonics. So if you like, so you can remember. So the mnemonics words are imagine. So E for emesis, M for muscular weakness, E for ECG changes, T for tachycardia, I for itching and rashes, N for nausea, and E for eczematoid lesions at the injection sites. So these are some important ADRs. Now another category of the drug is 4-aminoquinoline. So this is actually chloroquine. It is generally very much famous about it is actually an anti-malarial drug, but it is also effective in the hepatic amoebiasis. Absorption is completely from the upper GIT, and it is actually concentrated in the liver, and it is not effective in intestinal amoebiasis because it attains low concentration in the gut wall and lumen. Another group is amide group. So the drug is diloxanide furoate. It is synthetic luminal amebicide trophozoites in the gut lumen which form cysts are killed. Mechanism of action of this drug is after oral administration, it is split into the diloxanide and furoic acid in the gut. Diloxanide moiety is partly absorbed. The unabsorbed portion in the gut exerts anti-amoebic activity. So the dose of this drug is 500 milligram thrice a day for 7 to 10 days. You can give. Now the diloxanide furoate uses are first one is that it is actually the drug of choice for asymptomatic amoebic carriers. Another use is for complete eradication of the organism, trophozoites and cysts in the intestinal and extra-intestinal amoebiasis. So the diloxanide furoate and a tissue amebicide like metronidazole, this combination should be given and it is very much effective. The ADRs are of this drug rarely nausea and flatulence. So this is somewhat more safe. Nitazoxanide, another drug. So it is a luminal amebicide. It is converted to active metabolite Tizosanide. Uses are in the amoebiasis and giardiasis. Adverse drug reactions are GI disturbances. So now the another category of drug is 8-hydroxyquinones. So one very famous old drug is idoquinolone, quinol, and idochlorhydroxyquine. So these were very much famous and were used in the past, but it is now banned due to some specific ADRs. So the specific ADR is subacute myelooptic neuropathy. It was occurred in the Japan. So lakhs of and many thousands of people were affected with this. So from that incident, it was stopped. Antibiotics used in the condition of this bacterial infection. The main antibiotics used in this condition is tetracyclines. So it is luminal amebicide. It is unabsorbed portion of the drug. The unabsorbed portion of the drug reaches to the colon and inhibit the bacterial flora, which is essential for the survival of the ant amoeba histolytica. So in this way, this drug kills the bacteria. Paromomycin. It is an aminoglycoside. It is a luminal amebicide. It is not absorbed from the GIT. It alters intestinal flora. ADRs are the nausea, vomiting, abdominal pain, and the important thing to remember, it is safe in pregnancy. It do not cause the teratogenicity. Thank you. So this is all about the shigellosis and amoebiasis.